Thank you so much. Thanks for coming back after lunch or bringing your lunch in here. My name is Adie McKenzie, and I'm delighted to be here today to tell you about a patient that I had the pleasure of working with and the role of the CLT, myself in this case, in a patient with diagnosed Hypermobile Ehlers Danlos Syndrome and undiagnosed lipedema. Here's my disclosure. I'm a clinical advisor to Eros Medical. And about me, what you need to know is that I've been a massage therapist for about 40 plus years, and I've been in lymphology for about 15. So my purpose in this presentation was to just talk about this case where this patient came to me in a multidisciplinary medical clinic at Vanderbilt University Medical Center, where we treated many patients with the hEDS diagnosis. But I started to notice with my practice with these patients that many of them had characteristics that were consistent with lipedema. I'm going to try to use that pronunciation, but I'm probably going to go back and forth quite a bit. So hypermobile Ehlers Danlos disorder and lipedema are both disorders of the connective tissue with a growing body of evidence revealing that they are often comorbid. In this clinical massage therapy setting that I was in a integrative healthcare clinic at Vanderbilt, I noticed this very frequently with my patients, that they would have both of these presentations. And I believe that it is the CLT who may be the person most likely to notice these concurrent presentations and help the patient obtain diagnoses and appropriate care. So some of the potentially shared features are that these are inherited. They are connective tissue disorders in which the patient often has soft, velvety skin that's very stretchy, is often fragile, will bruise easily, and they often have difficulty with wound healing. They have, if there's a hypermobile disorder, obviously joint hypermobility, and that can lead to the frequency of subluxations and dislocations and pain and abnormalities. And these patients also often have gastrointestinal issues, other chronic inflammation patterns, and often the association of postural orthostatic tachycardia syndrome and mast cell activation syndrome. So this is my patient, and these photographs were not taken concurrently at the time that I met her. This is much later in her journey, but I was grateful that she was willing to share them and that she's eager to share her story with others in the hopes that it will be helpful. And it kind of echoes the presentation that we had earlier in the day about the family shared situation. You'll hear a lot of similarities here. She is currently 66 years old, has known for years of her hEDS diagnosis. She's the mother of 4 now adult children who all share that diagnosis. She tells me that she was 5'9" and 120 pounds until her first pregnancy, at which point she began having that disproportionate fat buildup with this quilted type fat that was painful and not responsive to dietary interventions. And she is a registered dietitian, so this was very stressful to her. She was originally referred to me actually by her daughter, who was seeing me for manual lymph drainage, simply to relieve some of the pain associated with the hEDS. And she came after having had an emergency colon resection, which led her to have 8 to 10 weeks after, without resolving, a stage 2 lymphedema diagnosis. So she was experiencing this lower extremity edema. She was very nervous about it. She was in a lot of pain, and she was not a fan of the idea of receiving massage therapy. In her opinion, that was something for luxury, for pampering, for vacations. It was not a healthcare intervention. So her significant comorbidities and comorbidities, I'm a little nervous. Oh, sorry about that. Thank you. Thank you. You all are so great. Thank you. So she had, as I said, she had stage 2 lymphedema at the moment that I met her. She had a history of GERD. She had had this colon resection and had a bag in place at the time I met her, and over the years went through 2 different revisions. She'd had a hernia with mesh repair. She had chronic pain patterns, chronic ankle problems, including a fracture. She had pelvic floor disorders. She was considered obese, which, considering her past, was very frustrating to her. She was dealing with chronic sinus infections and other chronic pain patterns and joint issues. So initially, when she came to me, I provided manual lymphatic drainage and told her basically about compression, and really wasn't able to offer her complete decongestive therapy because our clinic was not set up for that. Although I am a certified lymphedema therapist and there was a PT colleague there with that certification as well, we did not have multiple visits per week to offer her. We did not have any supplies. We were not able to bill insurance in my setting as a massage therapist. That was private pay in that particular clinic. So it was between myself and some of her other multidisciplinary team in this clinic that we were able to obtain a referral for her to a PT CLT in the community, and actually even closer to her home. And fortuitously, that PT CLT also had a diagnosis of lipedema. So there was a lot of opportunity for the patient to learn about her condition. She received the complete decongestive therapy, including graded mechanical negative pressure, which by this I'm referring to the cupping machines that many of us have seen used in clinics to help move fluid and also lift and stretch adhesive fascia. And in this case of this patient, she had some innovation from her PT CLT, who used a wound vac even after her ostomy revision was closed. It kept in place to help lift that tissue and minimize the scarring down. As you can see, she received the multi-layer compression bandaging, continued MLD both in PT and massage therapy, and eventually was referred to a diagnostician in Nashville who was able to confirm the lipedema diagnosis. Over time, she experienced a wide variety of manual therapy interventions, including myofascial release, which was helpful to her with both scar tissue revision and joint support. She also had other scar tissue mobilization techniques utilized to help address the post-surgical adhesions that she did have. She had deep Swedish-style massage, which helped to break up some of the lipedema nodularity and to address some of the fluid trapped in deeper compartments. Here I talk about gentle cupping massage, and by that I mean the use of a silicone cup that can be self-administered, and that was able to lift the tissue. And so instead of the press and stretch to provide manual lymph drainage, we would lift and stretch to move fluid. And she learned to use that for herself and also to use it in a way that could sort of help to break up some of those fascial adhesions. Kinesiotape did a similar type of job for the patient, and she learned how to use that herself for both joint support and lymphatic motility. And she became a complete devotee to aquatic therapy. She is a bit of an evangelist for that to others at this time. I feel that we were able to give her so many things between myself and the other CLT therapists that she worked with, and she has continued to recruit, not just me and her PT, but a couple of other massage therapists as well. Acknowledgement that what her symptoms were consistent with a diagnosis. She was not alone in what she was experiencing. We were able to validate the comments that she made about her experience, and we were able to offer her compassion because not only was it something that we feel compassionate about, but in her case of her PT, the lived experience. That is certainly an area where we can offer compassion. Education in what she might be experiencing, what it might be called, who might be able to help her with it, and referral. As I mentioned, she was able to get that diagnosis. We were able to refer her to other kinds of therapies as well that might be helpful to address anxiety and her various concerns about her physical status. We offered her resources such as the knowledge of organizations such as this one and other resources that are available virtually and in person. Self-care strategies, obviously I've mentioned some of those. Most profoundly for her, the ability to understand that aquatic therapy would be so beneficial to her. And all of that together, as we heard in that previous family shared situation, it is really helpful to have that kind of validation to help the family gather together to support the patient and understand perhaps what might be a potential for them in the future. This woman has 3 daughters. I think it's really important to recognize that manual therapists, PT, OT, massage therapists, spend an extended period of time with a patient. And that sometimes is going to be longer than other providers spend with them. It puts us in a position to hear a lot of comment about what is going on, to be able to respond to that and develop an intimacy with the patient that may offer that ability to sensitively help them understand what might be going on. In massage therapy, in my setting, I was not able to see a patient more than twice a month, but with PT, OT, and I am also a PTA, so I have worked in a lymphedema clinic where I was seeing a patient 3 times a week. That's very frequent, long interventions to get to hear a lot of information. So there are different rules depending on what role the therapist is in, and if we are in physical therapy and occupational therapy, we may be billing insurance. That's going to require certain specifics in documentation. That's beneficial for a massage therapist to document as well, because our notes can also be supportive in patients obtaining DME and other things that they may need in helping to inform other practitioners who are working with them. So it has that onus for the insurance company to cover, but then in massage therapy, there is the onus on the patient to come up with the financial wherewithal to afford massage therapy. Of course, that's not 100% of the cases. Everything is different depending on where you are. This presentation is specific to the United States. I can't comment on other countries and their rules. I believe an interdisciplinary team can be created whether we are in the same facility or system or not. And that is what we were able to do for this particular patient by involving a PT-OT who was in a different system, but we found HIPAA-compliant ways to communicate and to tag team and plan the best care for this patient. And I think that increasing interaction with educated providers benefits the patient. To hear information from a variety of ways of verbalizing it. All of us therapists are going to have a slightly different approach to how we share information, and that can expand the patient's access to all kinds of things that they need. So the outcome has been positive for this patient. She has really improved her well-being. She has now found the right kinds of compression garments. She has completed CDT, and over the 6 to 7 years that I've known her, she's returned a couple of times to get additional assistance. She now has her joints in better alignment, and she is feeling better in general, and she eventually did choose to have the adipose tissue reduction surgery and feels that that was also very beneficial to her, but she went through an awful lot of decongestion before she did that. According to her, she still likes to have massage therapy, and that's quite a reversal from where she was when I met her. She finds that this really improves her well-being in all these listed ways. It's calming, and she is still very involved with that. So my conclusion is that patients who have these diagnoses, both hEDS and lipedema, experience significant pain and functional limitations, and that skilled manual therapists, such as myself, can be very helpful using techniques to address those concerns, very calming to the patient, and that we offer these long sessions that are very helpful, and that this kind of referral should be considered by other providers. They should be telling the patients that they can take advantage of therapists such as myself. Further study is always warranted, and no published quality of life scales were used in my treatment with this patient, but she told me very recently that massage therapy is what keeps her going, and my jaw dropped when she said, my CLTs basically saved my life. So I do think there's an onus on us all to help our patients. And these are my references and resources, acknowledgments, and most deeply I need to acknowledge this patient for her desire to share her story in the hopes that it will help others. So thank you all for your time and attention. Please feel free to contact me. My assistant will make sure I get back to you.
We do have time for a question. How does one go about finding a qualified therapist?
Oh boy, that's tricky. There are a variety of organizations that have therapist listings. The Lipedema Foundation is putting together, and I am listed on their therapist site. I don't know all of the organizations. The National Lymphedema Network, the different schools that train certified lymphedema therapists, but all of us have unique training, and it may not be a perfect fit with each patient. So there is some finesse involved in finding the right fit.